We're going to discuss key differences, and towards the end of the video, we will discuss highly tested maltreatment facts. We are going to start off with intermittent explosive disorder. Now, the criteria for intermittent explosive disorder is verbal physical aggression for at least 2 times a week for at least 3 months, or 3 episodes in 12 months causing injury or property damage. These episodes are not premeditated, and the child must be at least 6 years of age. Of note, these episodes cannot be better explained by another disorder in order to meet criteria for intermittent explosive disorder. Now, clinical clues that you should be looking for in your exam is that these episodes have a very sudden onset because they're not premeditated, and these episodes don't last very long. There's typically tension before, relief during, and the remorse after. And the mood is normal in between episodes. And this is key because it helps distinguish it from DMDD, where the person is irritable all the time. In intermittent explosive disorder, the person is going to have these very verbally, physically aggressive episodes and then go completely back to normal. Treatment is SSRIs and CBT. Next, we have disruptive mood dysregulation disorder, or DMDD. So DMDD's criteria is there must be severe recurrent temper outbursts at least 3 times per week, grossly out of proportion to the situation. These symptoms must last for at least 12 months, and onset of age must be between 6 and 18 years, symptoms before the age of 10. Now, this is important. The mood between outbursts is persistently irritable, angry most of the day, and this is what distinguishes it from intermittent explosive disorder. We are going to discuss oppositional defiant disorder, or ODD. This disorder looks very similar to the other disorders we just discussed, so I'm going to point out key differences so you get them right on the exam. Now, they also have this maladaptive pattern of irritability, anger, defiance, or vindictiveness, but they are mostly argumentative and oppositional towards authority figures. They do not have physical aggression or violation of basic rights, unlike conduct disorder, and their defiance is towards authority figures. It's not these emotional outbursts at anyone. There must be at least 4 symptoms, such as argues with authority, deliberately annoying people, vindictiveness, irritability for at least 6 months. And it's important to note that unlike intermittent explosive disorder, DMDD, some of these behaviors can be premeditated instead of impulsive. Next, we're going to discuss conduct disorder. Now, in order to be diagnosed with conduct disorder, the child must demonstrate persistent violation of basic rights of others or societal norms. They must have at least 3 of the following in the past year: aggression towards people or animals, destruction of property, deceitfulness or theft, serious rule violations. So on a test question, you might see a teenager that's going out and doing drugs, but also bullying other people and stealing things. This would be indicative of conduct disorder. Now, this is very highly testable. Conduct disorder is a precursor to antisocial personality disorder. And the child must be less than 18 years of age to be diagnosed with conduct disorder. If they are at least 18 years of age, then the diagnosis is antisocial personality disorder. So be on the lookout for the age because test makers like to trip you up on that. So we've discussed these high-yield disorders. We're going to transition into child maltreatment, which is also highly testable. And test makers love to test on this because as physicians, we need to know how to recognize child abuse and report it. Now, child abuse can come in different forms. It can come in physical, sexual, emotional abuse, and in neglect. Neglect is actually the most common form of abuse, and this can show up as failure to provide food, shelter, or supervision. Physicians are mandatory reporters, and we do not have to have proof of child abuse in order to report it. If we just have a suspicion, we should be in contact with CPS and they will investigate it. Immediate safety of the child is priority. Now, for the exam and in real life, you need to know how to recognize red flags of abuse. So for physical abuse, there's a lot of red flags that can be recognized. Delay in medical care, inconsistent history or explanation. Now, a common history that they like to test you on, because it also tests on child milestones, is a baby rolling over before the baby is old enough to roll over. So the parent will say, oh, the baby got all these bruises because they rolled off of a chair, but they haven't reached that age yet where they can roll over. They do like to test on that, so know your milestones. Also, injuries and various stages of healing, old and new bruises, is a major red flag. Make sure that you know how to recognize spiral fractures on an x-ray, because they also do like to test that to see if you can recognize a spiral fracture and know that that is indicative of child abuse. The children could also have posterior rib fractures, cigarette burns, pattern bruises. And then another big one is head injuries. So they want you to be on the lookout for shaken baby syndrome. And in shaken baby syndrome, the child is going to have retinal hemorrhages. For sexual abuse, STDs in young children is a huge red flag. So is recurrent UTIs. Genital anal trauma, bleeding, or bruising also are red flags for sexual abuse. Now, children that have undergone physical, sexual, emotional abuse, neglect, they are at higher risk of PTSD, anxiety, depression, self-destructive behaviors, personality disorders, substance abuse. This can really mess up someone's life. It's not just for the exam. For high-yield child psych videos, click on the right. Otherwise, good luck on your exam.